community service, and we're based in and under Southwest London and St George's, and we're a team that, as we stand now, we've been working in this format for maybe over 2.5 years, but it was around before in a smaller format, with Aki herself being one of the main people working with Dr. Nurelli, and they were the founders really of the perinatal services. It's, I suppose, perinatal has been invested in, hasn't it, over the last few years, really, sort of recognising that there is a need for services across the country, really, across the UK, and sort of that the recognition that presentations in the perinatal period, if left untreated, can cause long-lasting developmental issues in children, cognitive issues, emotional issues in children, and also in the main, it can take the joy out of what should be a very enjoyable time, really. Having a baby is one of the most enjoyable times in a family's life, but obviously we know that there are kind of complications and through mental health presentations. So we cover 5 boroughs: Wandsworth, Sutton, Merton, and Kingston and Richmond, and our offices are over in Springfield site. And so we like to see, we bring our services to the boroughs, really, rather than people don't have to necessarily come to us at Springfield. We bring our services outwards into the community settings, and we see people in various settings such as GP settings and children's centres, maternity settings, and on occasions maybe sort of informal settings like libraries, wherever it is really that people can feel relaxed and that it's quite normal to come and see a perinatal nurse. And that is sort of to get away from the sort of severe sort of clinical settings. So the reason why perinatal services are set up, I mean, there's some hard facts really, that suicide was one of the most common causes of women's death in the perinatal period. That's after sort of cardiac issues. And as I said before, untreated mental health can create impacts on the relationships of the mother and baby relationship and the personal family relationships. And we know it can lead to vulnerability to abuse or neglect. And we know like risks can sometimes escalate, because we know something like domestic abuse can start to escalate or start in pregnancy. We know that about 20% of women develop a mental health problem during pregnancy within a year of giving birth. So our service, we complete effective assessments really to assess what is going on in the perinatal time, and we take a multidisciplinary approach to it. I mean, within our team we have a broad disciplines really, in terms of we have administration staff, psychiatrists, nursery nurses, occupational therapists, social worker, psychologists and nurses. And we're all trained and skilled in all aspects of maternal mental health and mother and infant relationships. And we hold in mind at all times the mother and baby and the family during all our contacts. And I think in essence, I think we consider ourselves a wraparound. We wrap ourselves around the family so that they can be the best. Because mothers have to wrap themselves around a new baby. So in essence, we offer that support to the families. And we work in partnership with a variety of services from, as I said there, maternity services, the GP, the health visitors, children's social care, IAPS, the volunteer section, and also the other teams like the home treatment teams and inpatient care, the recovery teams, and the other specialist services for such as substance and alcohol and eating disorders, domestic violence agencies and housing. And we get our referrals mainly from a variety of people, from GPs, from midwives, from health visitors, from other community teams, from the drug and alcohol services, And I mean, the midwives especially, they ask screening questions at their booking. When women book at maternity services, they are asked some key questions about their history of have they ever had a severe and enduring mental health presentation such as depression or psychosis. Have they been under services previously, and how are they feeling currently? And all midwives complete screening questionnaires such as the PHQ-9 and the GAD questioning, and on that screening then they refer to perinatal services. And so that's in pregnancy. And postnatally, health visitors also screen, and they ask about mental health at their contacts and ask about someone's well-being at all contacts. So when we get our referrals, we screen all our referrals on a daily basis, and we prioritise the more urgent referrals, and then we discuss them as a team, and we allocate to individuals to assess their new referrals, and it is, in the first instance, it's usually one of the nurses and doctors that complete the initial assessments, and then after the initial assessments we bring it back and present it to the multidisciplinary team and decide from there what is the best care plan for the family. And in the MDT there will be all the other agencies such as the social worker, the occupational therapist, the psychologist and the nursery nurse, and we will all think about the family together. I might just take that down just so that I can see everybody again for now. Oh yeah, now I can see you all again. So, I mean, when we go and see a family, first of all, we always like to, we introduce ourselves usually by telephone contact in the first instance, so we're already making that initial contact with the family, and we agree where to meet the person, where's the best place to meet the person, and we usually explain to the families how we have heard about them, where the referral has come from, what we know about them already, and the objectivity of us being there, and if they consent, really from the outside, if they consent to that, if they are okay with us being there, and at that point really just to ask if they have sort of any anxieties about being there, because pregnant women and mums with new babies, their anxiety will increase at this point, because to have us in the room, they may be sort of speculating with all sorts of things. You know, what if they share that they're not feeling so good? What does this mean? Will they be judged as not being an effective mum? You know, we know that families worry that their babies could be removed if they share too much. So, you know, from the outside, really, to get a sense really of their anxiety, so that we can try and contain it from the outside, that really we are there in the initial stages to assess and to formulate a care plan around their needs. So if it is a pregnant lady, we ask obviously how pregnant they are, what is their expected date of delivery. We ask where they've booked to, because already we're thinking about who we're going to be corresponding with in terms of maternal services. We'll probably have an idea at that stage about when they booked in as well, because sometimes we need to know if they booked in early or at the routine time for their pregnancy, or if it was delayed in some ways. And you know, if it was delayed, we sort of wonder how come it was delayed in terms of when you first presented as pregnant, because some women may delay seeing professionals about their pregnancy, maybe out of fear that that they're going to be judged, or fear that, you know, that, or they may not, maybe an unwanted pregnancy as well, you know, so they may be still trying to process the news about being pregnant. But yeah, just to sort of get a sense from that point of view. And we get a sense of what other pregnancies has been before the current pregnancy, and we find out the dates, the names and dates of birth of those children, and we find out if there were any mental health presentations around those pregnancies, and we find out then if there were any losses of pregnancy, whether that's through miscarriage or termination or children being taken into care, because we know that loss is very significant really, and women can experience mental health issues as a result of previous losses of pregnancy, whether that is through miscarriage or terminations or children being taken into care. And we know that if there has been loss, that the current pregnancy can create a lot more sort of anxiety. And then we look at previous births, really, about how was the birth? Was there any difficulty at the birth? Was there any trauma around the birth? I mean, we're sort of screening really for symptoms of trauma around the birth, if it was extremely difficult. And then we look at, maybe think about with the ladies about what was it like to give birth, if they have any fears about a new birth, because we do know about tocophobia, where women have a huge fear of birth. And if we can identify that early, we can work with that and try and treat that. And we look at whether the pregnancy was planned, was the timing right, is it good for them? Was it a consensual conception, or was there some sort of an assault to this conception?
Roisin, Aki's got her hand up.
Sure.
She's got a question.
Roisin, I was just checking, is your slide moving, your page moving? Because we're still on the first page.
Oh, I took it off so I could see you all. I'll put it back on in a bit.
Oh, because it's still showing.
Oh, is it? Oh.
It's still showing that you're sharing, so I wasn't sure. Sorry.
Oh, right, okay, then I'll put it back up again in a little while again.
Okay.
And so then if we're seeing a lady and the baby is already born, postnatal, and we sort of find out who else is working within the family, whether it is who is the health visitor, because all families will have a health visitor, and if there are any other agencies working with the family, whether that is through counselling, maybe through IAPS, or whether it's through social services, whether they have a children and family social worker. And we sort of ask questions around if the mother is breastfeeding or bottle feeding, and that is significant because if we're thinking about medication or what kind of medication, we like to know in terms of how the baby is fed. So when then we look at really what is the current difficulties, we sort of like to sort of find out from the family how things are now, how is life, how are they getting on with their new baby, what's it like to be a mum, does it meet their expectations, what are the difficulties, what are the thoughts and feelings towards the baby, and if there are sort of difficulties with the relationship, what does that feel like? Sort of to explore their feelings around the relationship with their baby. For some, I mean, at this point, you may hear something like, mums might think the baby doesn't like me, or the baby doesn't settle for me, but it will for other people, or I cannot leave the baby alone for a moment, or I worry about the baby all the time, or I cannot sleep because I need to watch the baby all the time. So we're looking. So at this point, that if mums are sort of addressing aspects of that, we're looking at their anxieties really in terms of other difficulties. I mean, what is it that maybe they feel that they have to watch the baby all the time, or do they feel like they have to, maybe for some, maybe do a lot more cleaning around the time they've had their baby, because a lot of mums worry about infection or contamination, and so we're always thinking at this point about presentations such as obsessive compulsive disorder, you know, which we know can become intensified in the postnatal period, or ruminating thoughts that, you know, maybe I'm not a good enough mom, or maybe some mums worry that they're going to perhaps drop their baby, for instance, or that some harm is going to come to their baby, so they feel like they have to constantly be vigilant, and they feel that that harm is going to come to their baby for some reason. And we look at really if they're sort of presenting with low mood, is it the timing of that low mood? Is it constant, or is it at particular times of the day or night? Some mums can present with feeling particularly irritable, which that can come as a result of pure sleep deprivation, because we all know what it's like not to have a sleepless nights here and there. But with new mums, it's a build-up of sleepless nights, 24/7, and most new mums are exhausted in those early weeks, early months. So, we sort of need to understand their presentation within the context of what is going on. So if it is something that they've had no sleep and they're exhausted and they're feeling very irritable, to sort of explore that a little bit further with the individual. And if the low mood can present as sort of feeling very low in energy, lacking in motivation, it can feel sad all the time, and to the point where they don't feel like they can maybe want to go out and do something, or they cannot enjoy their baby. And we look at then the presentation, we look at their history in terms of previous presentations to mental health, because in perinatal we see women that have maybe had a history of mental health presentations or developed new ones in the perinatal time. And we know 1 in 5 women do present with new presentations in the perinatal time, and that can be anything from depression, anxiety, to obsessive compulsive disorder. But we know women that have had previous histories such as psychosis or schizophrenias or bipolars, or maybe have severe obsessive compulsive disorder. They are more vulnerable to presentations in the perinatal period of time, and something like eating disorders as well. So for some, pregnancy can be a time where they can have very good mental health. In fact, a lot of mental health presentations can become dormant in pregnancy. But by finding out their history, we're sort of assessing their vulnerability, and we are then maybe potentially trying to predict what may be in the postnatal time, sort of knowing their history. We always have to know the history, what has come before. It doesn't mean that it's an absolute must that they will develop a perinatal presentation. However, it's very important, and the history is very important.
Roisin?
Yes.
I'll just ask a quick question.
Yes.
Is if somebody comes with a mental health history, how much is that kind of impacted, let's say? So if somebody had, they're in their 30s and something was in their teenage years, let's say, and they were perhaps not under any services as such at the time, how much would we be thinking about that going forward into the pregnancy?
Well, in terms of the history, I suppose we like to look back and think about what has come before, maybe in terms of their own early life experiences, whether that is maybe some trauma in their own early life, whether there's been neglect in their own life, maybe by their own parents, or whether there's been something like bullying at school, or difficult relationships that has come before, or whether there's been maybe coping skills such as maybe self-harm that has come before, that these aspects may not have reached secondary care services before, but they're significant in terms of their vulnerability and what, as I said before, what may be dormant up until now, but sometimes becoming a parent can bring out your own vulnerabilities in a way, because you are now, it's a sort of taking on a sort of the lead responsibility for another human being, really, and something about your own vulnerabilities can be triggered and provoked in the pregnancy and the postnatal time. So I think it is about sort of understanding the different perspectives where someone is coming from.
Yeah.
And some people, some may not make the links themselves. They just they may know that they're not feeling quite right. They're feeling unsettled. They may not have made their links to their own past life themselves. So it's up to us really when we're doing our assessments to sort of to be thinking about this, to keeping this in mind.
Okay, thank you.
Yeah. I suppose back to the history as well, we know that if someone has had a previous psychosis, whether that's a psychosis in a schizophrenia presentation, or whether it's in a bipolar presentation, or whether it's in a purely postpartum psychosis, or a previous psychosis maybe could be possibly drug-induced in history, that we know that those have a higher risk of they're at a higher risk of a postpartum psychosis, and maybe up to sort of 60% risk of a postpartum psychosis. So we are very mindful of this, and we, around women that have had sort of a psychotic history, we put them in a category where we actually complete pre-birth care planning for those ladies at 32 weeks, and that is within the NICE guidelines for treating maternal women, because we know to have such a significant history needs to be thoroughly monitored in the pregnancy and the postnatal period. And I'll explain a little bit more later on about who we do that pre-birth care plan with. But on the assessment, we also ask things about the physical health problems, such as any hypertension or diabetes or thyroid problems, because we know that thyroid problems can mimic mental health presentations, such as hypothyroidism, hyperthyroidism, in terms of low mood or elated mood, or it can bring sort of symptoms of it, sort of similar to presentations, really, thyroid problems, similar as anxiety presentations, should I say. And we ask about the physical health in pregnancy. Are they attending their obstetric care? Are they engaging in it? Are they having their bloods taken? Are they seeing their GP, if not the midwives? And if they're not, maybe how come? Explore that a little bit. Is it difficulty about getting there? In recent COVID times, we had women that were sort of fearful maybe of going to the hospital settings because they were fearful of COVID. So it's just a little bit of exploration, if they're not engaging. And then we ask about the family history, and we ask about perinatal family history. We do sort of ask around, if they know if their parents have got mental health issues, and if their mom maybe had any postnatal or pregnancy issues, and about other family sort of histories, just to see if there's any sort of significant and enduring mental health issues in the family, because we know that it is sort of identifying potential risks, and we look at the personal history. So again, like I was saying before, sort of significant events in childhood. So whether that is trauma history, whether that is physical or sexual abuse, emotional, verbal abuse, whether there's any drug or forensic history, and about maybe their education history, really, and that is just really to see about how they adapted really to maybe school environments, relationship history within schools, and because you sometimes get a sense of what people think and feel about themselves at that time, really, in terms of their own self-esteem or their own self-confidence. And then we look at their social history, because as Maslow's hierarchy of needs say, you have to have a balance. You have to have, the basics of life in terms of food and shelter and warmth, isn't it, around you before you can think about other aspects of life. And so we always look at really, I think conversations such as accommodation will come up, especially if there's a high need or if someone's in vulnerable accommodation. And we look at if there's any financial difficulties, and we look at, sorry, I just need to not make sure I don't log myself out. Yeah, now I'm back again. Because the financial and housing, those are basic needs in life, really. If people are struggling with those things, then if we identify that there are needs in this area, then we need to think about what we can do really to help. Because we need to think practically as well as emotionally and psychologically, when we're seeing families. And then we look at, we do know as well that people that maybe have been moved around a lot as well in terms of housing, that can leave them more vulnerable by nature, because maybe they're missing out on significant social support, or that they're meeting different professionals because they're getting moved through housing needs. But in perinatal services, we do a lot of transferring of care. So if a woman has moved from one part of London to another part of London, then the perinatal services will get in contact, and we do transfers of care from one perinatal services to another, and we try and make that like an easy transfer. So as all psychiatric services, then when we do see women or families for the first time, we look at the current presentation. So whether it is, how they're presenting with us, are they able to sit with us, or are they restless in some way? Are they able to look at us, or are they quite avoidant at looking at us? Are they able to get dressed, each day? Are they able to have a shower each day? But we also take it into context. If it's morning, and in their pajamas, it's absolutely fine. These are new moms, it's not, it is more in the main we're looking at if they've struggled, for days on end, to have a shower, days on end to put some clothes on. Is this a reflection of their mood at the time? And we sort of look at, if they're, when they're speaking to us, is it with a flow, or is it with some hesitancy, or is there with anxiety? Is it is there flow in the conversation, or is it that they're getting maybe confused at times, or distorted at times in their thinking? And
Roisin, can I just interrupt for a minute, because I think Kelly's got a question. She's asking about what if people are already under CMHT when they're referred to us? What kind of happens then? What do we think about?
Yeah, well, sometimes that happens in that we can actually get, because in our what we call our huddles or MDT meetings, we often have the midwife with us as part of our liaison work. And so we have become notified that a woman is pregnant, and we will check with the community mental health team, see if they know the woman is pregnant, or if it was another team as well, say drug and alcohol team or something like that. And then in some instances we will ask them if they require perinatal support. We sort of let them know that we can do some joint working, shared working, so if they've already got sort of a key worker, like a care coordinator, we don't routinely take over that care. We do more joint working together. So if it is that there's an identified need for a perinatal nurse, we can do some shared working and sort of think more about it from the perinatal point of view, in terms of how does this illness impact on the family? Does it impact on the family? Does it impact on the relationship? Maybe just to get a little more thought about the pregnancy, and the timing, and the postnatal time. Like I was saying earlier on, we are coming in with a different head space, as it were. We're very much thinking around the sort of mother-baby relationship and the impact of mental health on that relationship and the family. Does that answer your question, Kelly?
Yes, that's great. Thank you, Roisin.
So we're looking at, like I said before.
Sorry, Roisin, we've got another hand up.
Mm-hmm.
Let me just show, because I know you can't see when you're So I think Martin has got his hand up.
Yes, it's Martin from Healthwatch Wandsworth. Just a sort of follow-up question on that last point about the CMHTs. I just wanted to ask Roisin whether you feel that the generality of the CMHTs are sufficiently aware of the particular needs of women in the perinatal period. In other words, are they good at referring people to you, or do they need jogging?
Well, I suppose it's a mixed picture, because I think a lot of us maybe that work in perinatal have come from maybe CMHTs at some stage in our working lives as well. So we sort of understand the stresses, that comes with working, in CMHT. But I think what we have done through our time is that we've actually met with CMHT teams, and presented ourselves as aware, presented our work, and we always say we're sort of available to have cases discussed with us as well. I mean, every day we have, Monday to Friday that is, we have a duty person on, so that if somebody in CMHT have got a concern or want to talk about somebody, they can talk with us, or they can refer in, and we can have a multidisciplinary team discussion about a lady. I mean, as part of the planning and or part of the care and perinatal care, we actually offer preconception advice. So sometimes we do get the RST teams that refer to us for women that are on medications and they're wanting to think about starting a family. Then they can refer in, and we do offer consultations for preconception advice. And so that's in that consultation, we'll be very much sort of looking at the person's mental health history as well as the medications, and making recommendations. And that's usually with the psychiatrist, the perinatal psychiatrist in our team. So I'm not sure, does that answer your question?
Yes, I think so. I mean, I get the slight sense that you feel it's a bit patchy, and that you need to keep the story. I mean, I get the impression that maybe there is a need to keep reminding the CMHTs generally that.
Yes, and I think we I know that other disciplines can say that it's difficult sometimes to access CMHT teams, health visitors and midwives, that if someone is not under us, they may be trying to find out who the workers are, and they do talk about maybe having difficulties in communication. So I think the communication aspect is always key, something we always need to keep in mind. And
we do lots of kind of awareness, and we've done some training in-house, haven't we, Roisin, where we try and just kind of keep everyone abreast of what we do, and that we want them to refer to us, and because they're so busy, I think they do sometimes kind of just forget, don't they? That,
yeah.
I mean,
Yeah.
Is there anybody from any of the CMHTs on the line at the moment?
I don't know. We do have a question from Joseph. I don't know if it's in relation to CMHTs. Joseph, is it?
Not directly, but it might have a link. So my name is Joseph Manu. I'm a mental health practitioner working for Primary Care Plus Wandsworth. This is one of the newest service we started about 3 years ago. So we actually support people that have been discharged from the CMHTs back to their GP practices. So we are based in almost about 90% of GP practice in Wandsworth. I pick up from the joint working and the shared working, supporting people with perinatal issues. And I was throwing in there that because our service is new, I think it was recently that we had only one referral from your service, from I think Dr. Lena Patel also. So talking about joint working, we will be able to take referrals from your services when people have come to you and then they don't belong to any community mental health team and they are being discharged back to their GP. We will be able to support them if they have mental health issue, anything related to their emotional well-being, diagnoses like psychosis, bipolar, anything related on the SMI register. We'll be able to do that. So I thought this is the time to throw in that we are also there. A lot of people don't know us because it just started about 3 years ago, but we will be able to work with them. But we work closely with the CMATs and they do referral through us before people are discharged to the GP. So, yes.
We had your manager visit our Wandsworth referrals meeting recently, Joseph.
That's good. Cat Hunt,
Yes.
Is that correct?
So
Beautiful.
he did tell us all about it and about the serious mental illness register that they need to be on to be referred to you.
That's good. Thank you for knowing. So that I think the whole of these meetings will be able to share this information, make sure that people have the support and the resources, and work together to make sure that they are supported with their recovery. Yes.
Yeah. And Aki has also mentioned that we have, Martin, link workers for each of our CMHTs within our team who try and attend sort of regular meetings at the CMHTs just to kind of say hello and talk about any perinatal issues. And we're also trying to encourage CMHTs to also have a perinatal champion, someone who can be that link with our team.
Yeah, so maybe I'll take this to my team. We might have a link champion because they are very kind of important group of people that need support when you thinking of bearing a child and having worries and concerns and not getting the right support. So I might even present to my team that we might consider that. And then John, you mentioned about CMATs. I don't work directly with them, but I do attend their link meetings, especially East Wandsworth. And each of our clinicians attend other CMAs. So if there are some of the things we can also take back to them in their meetings as well. Yeah.
Thank you, Joseph.
Thank you.
Okay, so I'm just thinking a little bit more about when we see our families, and as I said before, we're very much keeping the mother and baby in mind together. So when we go and see women that have had their babies, I mean, we do observe, we do think, and we ask around the relationship with the baby, and so we sort of look and how we sort of see how mom is with their baby and their other children, really. You know, if they're able to respond, you know, to the baby in a caring way, you know, or you know, are they able to look at the baby? You know, where is the baby? You know, we always like to know where is the baby. We like to see the baby, you know, and we like to know about, suppose where is the baby in the mom's mind? You know, is it a forefront of her mind, or is thinking about the baby create a lot of anxiety within the mom, a lot of worry? Is the mom is she thinking about the baby's maybe developmental needs, you know, for the time it is, or is she worrying about the future, you know, not able to sort of think about the present? And we do ask about, you know, we ask explicit questions about have they got any sort of abnormal thoughts around the baby, you know, have they got any thoughts to harm the baby at all, or do they worry about harming the baby, and sort of unintentionally. You know, like I was saying before, sometimes in terms of their anxieties, they may have, you know, some mums with maybe perfectionistic personalities may think that they have to be with the baby 24/7, that they cannot put the baby down. So, or yeah, so it is sort of getting a feel about what's it like to be a mum to this baby, you know, and how do they describe their baby? Some mums might say, oh, the baby's beautiful, you know, love the baby very much. Other mums might say, oh, the baby just cries all the time. I don't get any peace, you know, I can't put the baby down. And so we sort of explore that with them, you know, tentatively, you know, caringly. We explore that with the families, really, you know, what is that? What does that mean, you know, to the family at this time? You know, is mental health impacting on this? Is it just pure contextual? Is it sleep deprivation? You know, is it worries about something else, like I was saying earlier on, financial or housing, you know, or other children, you know, in the family just needing all the extra time, or other stressors that's around, you know, or is it something like domestic violence, you know, in the home? You know, there's just always trying to understand what is going on at the time. So I know we've only got so many minutes left, but really in terms of a lot of our work in terms of about risk assessments really is about, we know, I mean, the risks around the perinatal time is, so it is the risk of harm to the baby or other children, so whether that's intentional or unintentional through mental health, so, or whether it's through sort of physical neglect or emotional neglect, and also we're looking at sort of the risk to the mom and maybe other members of the other family. So whether the mom has had any sort of thoughts of to harm herself, you know, whether self-harm, whether they are self-harm, because especially if they're self-harming in the pregnancy or the early days postnatally, is that a sign of escalation in mental health presentation? You know, it's a worrying sign for us.
I was just thinking, Roisin, about the recent maternal report about the red flags and how that's one of them. That sense of
yes,
if mum's got new thoughts of self-harm, or
yes,
that she's a bad mother or not going to be a good mother, that's a real kind of red flag for us, that if it's a new thing.
Yes, and especially, you know, if suicidality is a sort of a new presentation, you know, some mums find that, you know, as Jill just said, that they don't think they're going to be, you know, that they're not a good enough mum for this child. This child would be better off with somebody else, you know. And if we hear mums talking with that sort of thinking, then that is to be taken very seriously, because you just maybe a sense of hopelessness and helplessness, you know, and they're not feeling confident in their role as a new mum. And then we look, I mean, in terms of risk, we know that in the perinatal period, they talk about the trio of risk. So if there is something like substance misuse or domestic violence or childhood abuse and neglect, and mental health issues, you know, we talk about those as very significant risk factors in the perinatal time. They talk about it in terms of, you might have heard it talked about the toxic trio they talk about in terms of mental health, substance and alcohol, and domestic violence, because it's a combination that creates high risk. And then we look at risk of if the mum or family are being harmed from other people, you know, again, whether that's you know, maybe through domestic violence or neighbours or institutional harm, or, you know, if there's any harm coming from other people to the individual. And we look at the risk of social isolation, because we know that's very significant in the perinatal time, because support, you know, support carries us, doesn't it? And in the perinatal time, it can be an isolating time, because you know, mums can have new babies, and then, you know, they may have been working up until this point, and then suddenly they find themselves at home alone. The partners have gone back to work, you know, families are not necessarily around the corner. So and social isolation can be a difficult time, and so we just ask who is there to support the family, who is around, who can help. And if there's not, then we can think about that. We can think about organisations that can help, and we do know, especially in the last year of COVID times, you know, that mental health issues have risen, and a lot of that is in relation to isolation and the fact that a lot of agencies have not been working in the same way. You know, children's centres have been closed, some of the voluntary sectors have not been available, you know, and so we have found that in these times. Then we look at other risks, sort of risks of maybe families that don't want to engage with us. We wonder, how come, why not, what's going on? You know, we just don't accept it as, you know, do not want to engage. We wonder a little bit more. We talk about it with the family, we talk about it as a team, and we reach out to other professionals to see, are they engaging with other professionals, you know, whether that is the health visitor, the midwife, or, you know, the children's centres. We just wouldn't close without knowing those things, because we do wonder how come they're not engaging. And then we look at maybe if someone is being commenced on treatment but they're not really complying with it, you know, again, how come, why not? Is it a fear of taking medication? For some, the fear of taking medication in pregnancy, or the fear of taking medication while breastfeeding, we explore that, because and we give them information about taking medication in pregnancy. We do know that many medications are prescribed. There are not many that cannot be prescribed in pregnancy and postnatal times. And we know there's been lots of, I suppose, mixed information out there about medication in pregnancy and postnatal time. But I mean, under us, we can think about that, and we can give information that helps give people the most informed choice really around medication and breastfeeding. And so we're always thinking about safeguarding concerns to do with mothers and babies and their and so safeguarding plays a key part in our work in terms of identifying, first of all, potential safeguarding concerns, and that is through communication with the family, through communication with other professionals, and through our own observations as well. And we work closely with Children and Family Social Services, and we attend child in need meetings, child protection conferences, and it is all about, again, like I was saying earlier on, a wraparound service around the family in order to promote family life, reduce mental health, or reduce the impact of mental health on the family. And support families to sort of reduce adversities in a way, you know, so that mental health can bring onto families. And at the end of our assessment format, as we write it out, we write it, we give it in written communication, and we write the formulation. We give it to the mum. We give a copy to the mum. We at the beginning, we sort of talk about who we're going to share our information with. So, I mean, and we sort of explain the reason for sharing, because sharing is about, it's about communication, and it is about, for some, it's about not having families not having to repeat their stories all the time to different professionals. It helps them feel understood, and it's also about sharing sort of potential relapse indicators, so that other professionals can equally watch out for that. So say a midwife going into the home afterwards, or a health visitor, you know, they can keep in their mind that this particular family may, you know, or this particular mum may have low mood, or, you know, have had a history of psychosis. And communication.
Sorry to interrupt, we've got a question from Kelly, I think. Hang on a second. I'm just aware of time, because we've only got 5 minutes left. I think Aki was asking about the rest of your slides, if you've got your other slides.
Okay, let me see what I've got at the bottom of that. So you can see something.
Kelly was asking about assessment tools. That was it. What assessment tools do we use?
Yeah, so when we use screening tools, we have our own perinatal assessment tool that we have formulated ourselves, and it's all in within the perinatal guidelines. And we also use our core 10 ourselves. And if there's domestic violence, we can use the domestic violence tools for questioning. And we use, I mean, obviously in the trust we use HUNTS as a tool. And in terms of diagnostic criteria, we think about the we use is it ICT-10 we use in the trust? I keep forgetting what do we use for our diagnosis? DSM, yeah. And when we think about when we're diagnosing, we think about that after our assessment and as a team. Yeah, let me see if I've got. So you can see something on screen, because I can't see that now actually in terms of what I've put up.
We've just the initial your initial slide that you showed, sort of with your overview that is on the screen at the moment. Martin, is that your hand or is that an old hand up? I don't think you can hear me. So we've just got a couple of minutes left. I don't know if anyone else has got any questions. You can put them in the chat or come on and ask.
Could I ask a couple of just short questions? You mentioned about who the people you were working with, which appeared to be mainly with psychosis, OCD, eating disorders. Do you also deal with people with PD?
Yes, we do. Yes.
You do as well?
Yes.
Okay.
Yes.
And also you're talking about the up to a year after EDD. In sad cases when there's stillbirth or late stage miscarriage, do you still continue to work with those ladies as well, or?
I mean, after, it depends on if it's a late stage miscarriage. We do offer a follow-up, but the follow-up really is about formulating aftercare really with them, because unfortunately we don't work with them long term after they've had a miscarriage. We do have to direct to other services. Okay,
thank you.
That's what we hope our mental health awareness clinics that are being built up around the country will be able to take and help those women in the future. That's the sort of long-term planning. It's a gap.
Yeah. I didn't mention dad support there. We do have dad support as well, and we always think about the dads as well, partners. If there's not dad, if there's partners involved, because we do have access to support for fathers.
Yes, I'm just putting up Deanna Freud website for the Mind the Dad project, and that is all self-referral for any man in London with a child under 2.
And I think on Friday, Alex from Mind the Dad is going to talk about that in his session in the morning.
Yeah, and I just put up there at the end of my write-up there was just we do have close working relationships also with the mother and baby units. So if mums need to be admitted into hospital, we admit them to a mother and baby unit most of the time if there's a bed available.
Brilliant.
There's another hand up, I think, Martin.
Yeah, yes. Well, we're coming to an end, so I wanted to say thank you very much to Rasheen for a very rich account of the assessment process, which is very kind of impressive and reassuring. I did just want to ask about how much of the, I mean, you said there is a written formulation at the end.
Yeah.
Is that shared with the maternity services and or the health visitor as a matter of routine?
Yes, we do. Yeah, and we do also have that discussion with our mums when we meet them first about the sharing of information, and we do seek their consent. Yes, and we do share in the main with the GPs, the health visitors, and the midwives. Yes.
Thank you. Thanks very much.
Okay, we've reached the end of our time.
I don't know whether people can see the end of my little write-up in there or not.
There's a couple of people who are asking for a copy of your slides, Roisin. If you have a look in the chat, the couple of emails there for you to forward that on, if that would be okay.
Yeah, that's okay. It's just a little something I put together myself. So I mean, if people find it helpful, I can share it. That's okay.
Yeah, I think it will be very helpful.
Okay.
We can also echo your voice to our teams, because this is very, very informative and very useful. So thank you so much. I really enjoyed that. I will have to leave for one meeting now. So thank you. And I hope we'll catch up at a point. I've sent an email to my people that they should look throughout the week for the brilliant sections that you are putting up. And I think people will enjoy it as well. Thank you so much.
We have a user sharing experience at 2 p.m. today, Joseph. One of our ladies is coming to share her experience. So
yeah, I might tap in when I have a less busy clinic. Thank you so much, Jill, and then Roisin and everybody that took part in it. Thank you.
You're welcome.
Thank you. That was amazing, Roisin and Jill and everybody else who asked questions and so kind of chipped in. So thank you for kicking off our session. It's very exciting.
Well done, Roisin.
Oh yeah, I can't see you all. Let me see you all now. Okay.
No, but I said that I'd log in when you was on today because I remember. Yeah.
It's very disconcerting